So why have we chosen the art of involving? There are many words we could use. Some people use consultation, but I think that's a bit passive, to be honest, and is something that tends to be done to people. Kieran mentioned co-design and co-production, and we thought about that. We thought about using those words, but I certainly am not quite convinced with those words yet. I think there's a danger of the NHS, certainly, and public health system and public sector co-opting those words and using them to mean what they always wanted to mean anyway. So using co-production and co-design to mean really just the sort of the bog standard consultation that we all know and love. So we've used involving. Some might say that we've been deliberately vague in using that word. Now, I know that none of you in this room would, because you're all lovely, supportive people, and you would say, actually, we've been deliberately inclusive by using the word involving. I think the key thing is it's about being active. It's about proactive. Get involved. That feels like an active thing. So that's why we've chosen involving. And the reason why we've chosen art is because those of you who know me know that I'm stupidly reductionist in my thinking. That's just kind of the way I'm wired. And so my team berates me for this on a daily basis. I'm trying to find my head of art strategy because, there she is. There's Nikki. Yeah. Nikki always berates me about this and says, actually, there's really an art here. It's not a science that can be reduced to a formula. There really is an art here. Nevertheless, given who I am, we have decided that we would try and distill that art into 5 principles. And those 5 principles are all born of the lessons that we have seen from the work that we supported you to do. So in a sense, they're your principles, they're your lessons. So if you don't like them, then it's kind of your fault as well. But in the spirit of involvement, we can all talk about that later on today. So I'll just give you a quick overview of the principles that we've distilled, and some of them, they're on their tables. I hope you've chosen tables based on the principle you liked. So the first one is understanding and valuing expertise. It's getting rowdy over there. Understanding and valuing expertise of everyone. And I think this is really important because I've been in the room at those meetings where you're sitting there with Professor Reza Razavi, who has 1 billion degrees and the brain the size of New York, and you think, what can I really do? What do I know versus Reza? And of course, I'm still the expert in my own life and in my own experience of care. And Reza, being a good clinician, actually knows this, and so you can have a good conversation with him. But I think it's really important that everyone understands and values the kind of different perspectives that people can bring, and that they have equal weight, if you like. The second principle is balancing leadership with handing over power. Now, I instantly actually don't like what I've written down because of the phrase handing over power. So I've got that wrong now. So you can see we're kind of designing as we go along. But I think the important point here is that sometimes what I have seen in NHS events that are badged as co-production is a sense of almost an abdication of responsibility. And sort of, well, you just tell us whatever you want and then we'll kind of go and make that happen. But that's sort of fantasy because everyone in the room knows that that's not the case and you have to make choices, and there comes to a point where you do need to decide. There is only so much money and we have to prioritize, and the leaders of the system do need to show leadership. I think the way that they do that is really important, but I don't think involvement is a way of abdicating responsibility. Third principle is go where the people are and use their language. One of my most hated phrases, let me read this side of the room now, most hated phrases is hard to reach groups. So sad, so sad. There are no such thing as hard to reach groups. There are groups you can't reach, and you don't know how, but there are no such thing as hard to reach groups. And we're going to hear a bit later about how that is definitely true. Fourthly, involving people at all stages. I think this is really vital, that you do go on the journey with people. It's not just having that instant in time, that moment in time where you just have that consultation and that's it, we've consulted you, isn't it fantastic? You've got to take people through the journey. I don't know yet how we balance that idea of representation versus kind of depth and going through the journey, so that's maybe something you can discuss. But I think taking people through different stages is important. And then lastly, the last principle is, this does take time and effort, and you've really got to put the resources into it. I think you all instinctively know that, but this is hard work. It takes time to build trust, and that's fundamental. So we've got those 5 principles. But going back to what I said earlier, this is an art. So those principles are guiding. And I think one of the things that's really important that underpins the principles is really the behaviours and values that you demonstrate. And actually, this is more important than the principles. Probably the best way of putting it is you've really got to feel it. You've got to be authentic in involving people. And if you're not, people will spot that really quickly, and then they will know that it's false. So you've got to mean it. You've got to be authentic. And in a sense, you've got to have those early discussions that are difficult, where the clinicians and the patients are perhaps talking at cross purposes. You've actually just got to go through that. I've seen this in a number of projects. I saw it in Slick. I've seen it in others. You can't actually avoid that stage, much as you might like to because you want to get on with it, but you need to spend the time on it.
I'm Sally. I'm a clinical psychologist and acting clinical director at MAC UK.
Hi, I'm Taz, and I'm a youth trainer and consultant at MAC UK and the Integrate movement.
Thanks, Taz. So, so we're going to talk to you today. I don't know if we've got the slides, but we're going to talk to you today about our charity, MAC UK, where co-production is absolutely at the heart of everything we do. So the question that our charity started with is, how do you transform poor mental health for young people who have absolutely no trust in services? They don't trust the system, and services are absolutely terrible at reaching them. Excluded young people, in other words, in our communities. Young people who are affected by issues such as gangs, sometimes young people who might be victims and perpetrators of violent crimes. They have difficulties with mental health, not surprisingly, because they're living in difficult conditions. They're living in a melting pot of poverty, exclusion, violence, stigma, drugs, struggling communities, lack of social cohesion, family difficulties, and peer conflict. So we know that 1 in 3 young offenders have an unmet mental health need at the time of their offence. Thank you. Cool. I'm also aware we've got 8 minutes, so I'm going to be moving very fast through this. And we learned very quickly that it's not just what's in their heads, as what is often associated with mental health. It's very much what's in their worlds. And the only way to tackle this was to go to the streets and ask for young people's help. And essentially, that is what our evidence-based and community-based model that we've called Integrate is all about. I think we work intensively for between 2 to 4 years with up to 100 young people, working in partnership with other agencies, and really innovating around co-production, which I'm going to come on to tell you about. The young people are amongst the 5% that commit 50% of youth crime and have a history of non-engagement with services. So, I'm going to speak. How does the Integrate approach? No, that's all right. How does the Integrate approach innovate around co-production? We make people the architects of their own support. And that's exactly what I think Ollie was just talking about. We start by asking young people for their help rather than offering our help. We put them at the heart of the design and the delivery of the services that are needed, and we step back from trying to do things to them. We move from seeing them as objects of our care and start seeing them as the architects of their own support, away from the idea of being burdens on services, which is a very strong narrative at the moment, to assets in their communities. We harness the expertise that we don't have as a mental health professional to help us design and make services that work for them. Our goal is to make sure that both forms of expertise, our own clinical practice, our evidence-based practice from the clinic, is taken out onto the streets where young people are, but that we also take into account the lived experience and the expertise of those young people who are living in those communities. And that's worked incredibly well for us and continues to do so. So what does this mean in practice? We go where young people are, as I've said. Sometimes it's literally hanging out on the streets. Other times it's finding spaces where young people spend time. Like sometimes you're lucky if they're in youth centres, but many young people are excluded from youth centres. But what we do is find community gatekeepers, and we run a peer referral system, which Taz is going to talk to you about.
Hi. So if you were to get into Mac UK, they would see me where I'm youth unemployed. They would come to me where I've been involved with the organisation. They feel that I'm somebody that they can look up to and that they feel safe, where we have built a trust now within our relationships. So it may be, for my example, when I first started off with Mac, I was approached on the streets by some young workers who then helped me bridge into other services, helped me with housing, and helped me get employed and other issues.
The peer referral system is absolutely key to what we did, and it was young people that told us that this would work. They would bring other young people. Taz is a leader in his community. He was trusted by other young people. It was a word-of-mouth approach. And if young people saw other young people getting support, they'd bring the right people along to the projects. So this is part of what we've developed in terms of our Integrate approach. Some of these ideas may be familiar to you, but it's this idea of spending time in the community, hanging out, asking for young people's help, which we genuinely and authentically need, and young people leading on projects. Taz started a gym project, which he then engaged other young people to become part of, and weaving in mental health support through those relationships, something we've coined street therapy. But is essentially what a lot of people have been doing in the past, but we've found a way of communicating it. We've found a way of operationalizing a more informal form of mental health support. And young people support each other in the same way and learn the skills of street therapy. We then build bridges between young people in their communities and young people in those other services to actually support young people to reach the services that are otherwise. I'm with you, Ollie, on the hard to reach. It's services that are hard to reach, and so we make them more accessible. And then young people become involved in youth-led training, dissemination. Taz has been to the Home Office a number of times now, much to my frustration, and work at the policy level as well, and at the community local government level. We've had one of these Integrate projects in Peckham in Southwark that was funded by St. Guy's. It was called Reach Out Outreach. Maybe we can, I think there's, yeah. And we've got 4 other pilot sites of this approach, one now in Haringey and Tottenham, and each one engages over 100 young people. It's actually incredibly easy to engage young people if you find the right methods. So, and part of that is an attitude. It is about balancing leadership. It is about handing over power. And it is about trust. And it is about positive risk-taking. And it's about saying, sometimes you need to employ young people. And they need a lot of support to take that first step into employment. And I'm going to talk a bit more about that in a second. So we don't do it on our own because our aim as a charity is to transform, radically transform, I'm going to add in a radically transform the way mental health services work for excluded young people. We're not saying this is the way that all mental health services need to work. We are saying this is the way that we think we need to work if you want to reach the groups of young people who need it most and are least likely to ask for help. And we do it in partnership. So our projects are in partnership with other agencies. As you can see here, this is our example of the partners that we have with Reach Out Outreach, which was the Peckham. And similarly, in our Tottenham project, we have a multi-agency steering group from local government, from the council, from the NHS. And as in the same way that we involve young people in decision making, we also share dilemmas about the project and its operations and its clinical governance with that steering group, so that our partners are also co-producing the project and learn some of the enablers that you need, like the clinical governance and the operational governance that you need to make this work. So, what works well about our Integrate approach? And Taz, if you want, I should say Taz is going to get me at any moment if he wants to add anything. It's an early reality check. So right from the word go, young people would say, nah, that's not going to work if you want to engage young people. What you need is a music studio. And sure enough, they help us create a music studio, and that's what young people come along to and build relationships through. Our ideas about what's good music, as well, as you can imagine, it's not the same. So there's an early reality check on what to do with your projects. You don't need these outcome measures at the end that tell you what you should have done. It's an ongoing process. It changes the power relationships. It values those who aren't valued, and it gives you young people a different identity from the identity that they see themselves in within society. It harnesses assets, and it develops a workforce that needs a lot of support, but a workforce that then, thank you, Rosa, that then has a lot of empowerment, a lot of strengths, and a lot of places that they want to go with their lives. And Taz can talk about some of the other things he's doing if we get a chance. It builds trust, that we're transparent, we share our dilemmas and our practice. We say when we think we might have got it wrong, and young people respect and open up to that. And it builds capacity in the community. So we try as much as we can to give young people the ownership back of the projects, of what happens next to the projects, what they want, whether they want it to continue or whether they think it should become something else. And similarly, back to statutory services, we want to hand it back to the community. And it changes, and our aim is, as I was saying, to change the way statutory services work so they are more accessible. MAC UK do not want to be delivering the frontline work. We want to see the NHS doing it this way. We want to see the local authority doing it this way. And it builds social capital. In other words, young people build their own social capital through the networks that they come in contact with. But more importantly, as professionals, young people build our social capital in the community, and we couldn't do it without them. Is there anything quick you want to add to that? The challenges. It takes a lot of resources. It's slower. It takes time. You need more human resources. You need people to support and wrap around your youth employees, your community gatekeepers, if you want to make it work. And you need to spend some time with stakeholders and building relationships in the community that would otherwise not be considered mental health work. There's inefficiencies in it, although I question the use of what inefficient actually means, because in the longer term, you're moving towards prevention and building capacity in the community. But it does take longer. It's not standard job training, for example. And it takes a lot of time to think through a lot of the dilemmas that come up in the work. And it's difficult for the NHS to adopt some of that learning. It's difficult because we have very flexible employment governance. We co-produce our employment governance as much as possible, supporting young people to think about what should be the boundaries, how should we support them, how can we push them forwards, that kind of thing. And it's harder for the NHS and statutory services to do that.
So by way of quick introduction to the topic, we know that we have a changing surgical demographic with increasing numbers of older patients presenting for surgical procedures. And whilst, of course, this is a good thing that we would laud, there are, of course, problems with this. And we know that our older patients suffer from an excess of post-operative problems in terms of both mortality and morbidity when they're compared to their younger counterparts. And whilst this has been recognised in the academic literature for a while now, it's really become more prominent in the national discussion because of these series of national reports where we see that these problems older patients have after surgical procedures aren't really being met by the services that we try and provide them with. And part of the message from these reports is that our preoperative preparation processes perhaps haven't kept pace with the problems that the older population have. So this set us thinking as geriatricians locally, well, what can we do to try and improve this? And we have a method we use as geriatricians called comprehensive geriatric assessment and optimization, which is exactly as it sounds. It's a multi-domain assessment of a patient where you then put in place plans to try and treat those things you've found. And they might be medical things, so optimizing people's heart failure or anemia. They might be social things, so ensuring that occupational therapists or pharmacists are involved, getting people doset boxes to take their drugs, ensuring that people have adaptations at home. Or they might be psychological or functional supports, so therapy to progress people's mobility, that kind of thing. And we know from the academic literature that this process of CGA works in that patients who go through this are more likely to be living on their own and with less cognitive and functional problems at a 12 or 18-month period. But it hasn't been well tested in the older surgical population. So this is the overview of the research project which we undertook, and I'll quickly give you this part before I go to show you how we then designed it. So the hypothesis was that if we used preoperative comprehensive geriatric assessment and optimization, we would improve outcomes for older surgical patients. And this study was a small randomized controlled trial undertaken locally at GSTFT, where we compared patients undergoing this innovative CGA clinic against what's normal care within the trust. And the results have been submitted for peer-reviewed publication, so I don't want to really dwell on that, but suffice to say, we had an encouraging outcome from the trial, and we think that the reduced length of stay we saw in the intervention group pertained probably to the reduction in medical complications and problems with getting patients out of hospital at the end. So given that quick overview of what the project actually was, how did we design it? And I think really lots of what we've heard has been mirrored in our experience, although with a completely different group of stakeholders. So we went out in the observational phases of these projects and spoke to everybody. So not just the usual suspects, the service users and their relatives, our surgical colleagues, our anaesthetic colleagues, but we also spoke to hospital managers and we spoke to people on the ground doing the job. So key, for example, in that process was the administrators who call patients up to tell them when they're coming in for hospital. So so-and-so has booked you for a surgical procedure, you've got to come in on Tuesday for an operation on Wednesday, this is what you need to bring. People who are making those kinds of phone calls. And we went out and we spoke to everybody about this. And what was really interesting is that often when we've done these things in the past, you might sort of think you know what answers you're going to get. And we'd spent a lot of time in the past designing similar studies where we'd put hours of work into huge, great big patient information leaflets, lots of time for patients to think about it, decide if they wanted to be involved in anything, talking to their relatives about whether they wanted to be involved. And consistently what patients came back and told us through this process of designing this study was that they don't want to be bombarded with tons and tons of bits of paper about studies. They don't want to be called multiple times at home by a research team saying, have you had a bit of a think and do you want to be in the study? Actually, what they want to do is get a concise overview of it from somebody involved and decide there or then what's going to happen. So this really turned on its head those kinds of experiences we thought we might have had in the past when we tried to design studies with patients and service users and their carers. So the effect on our study design from this feedback was that we applied for ethical approval to simultaneously approach, consent and randomise patients to either receiving care in this innovative CGA clinic or in the normal service. With our discussions with managers and other clinicians, unsurprisingly, people didn't want patients having very long hospital stays. There's a financial cost. We know they're more likely to have complications. But when we were designing this project, what we really wanted to make sure was that we weren't just using clinician-reported outcomes, and we were using measures that were important to patients and their families. And actually, it was very encouraging to us when we started to think about the outcome measure for the study and how we were going to power it, that again, overwhelmingly, the patients that were involved in the design of this didn't want to be in hospital a long time. Their families were less concerned about that, but more concerned that the process at the end, where patients transitioned from hospital back to home, was very well managed and was proactively managed, so they knew what they might expect in terms of carers going in or in terms of rehabilitation at home. So it sort of fed into this same primary outcome measure that was then palatable and relevant to both patients, but also to the clinicians and the managers. We obviously spent a lot of time with the surgeons, and as we've heard from our previous speaker, we went to speak to the surgeons in their own environment. So we went to their audit meetings. It's a great place where we could present our data from observational work to then have a proper dialogue about how the next study might look. And they were very anxious that if we started tinkering around and fiddling in the process of care for the patients, that there'd be a longer gap into surgery for those patients. So we spent a lot of time with the surgeons looking at that pathway to try and make sure that whatever we did would work within the timeline that they already use. The administrators that I mentioned earlier that we spent time working with, we went to their offices to see how they do it so that they could explain to us where the problems were for them. And what they were very clear is that there's often mixed messages for them and that they're the point of contact for the patients, but the anaesthetist might say one thing, the surgeon might say another, the physician might say another, practically there's no bed, and that they found it very difficult to know what to tell the patients. So we used that in our design and made sure that the way we documented the outcome of our clinics went straight to the administrators with a clear message, and that they had our phone numbers so they could call us if there was a mixed message and they didn't know what to tell a patient. So very much fed into things that we would never have conceived of doing without that kind of process of designing the piece of work together. And of course, as you do in research projects, we spoke to our health economic and statistical colleagues early on. But certainly, as someone very inexperienced with health economic analysis, found that process very useful. And we collected variables we wouldn't have collected otherwise. So in terms of this project from a research point of view, what were the benefits? Well, we recruited well and quickly and in accordance with our timeline, which often doesn't happen, as people will know when they've had experience of these things. And not only that, but we retained all the patients that we consented and recruited, so nobody dropped out of the study. And certainly moving away from the kind of recruitment edge into the process of the clinical decision-making as part of the project, I felt very much that the decisions we were making with our surgical anaesthetic and therapy colleagues were collaborative decisions. It was a very kind of open forum of how can we best provide care for these patients involving their wishes, but also our wishes as professionals. And I think that was partly because we had good buy-in from everybody about the project. We weren't imposing something that we thought might work as geriatricians on a bunch of other autonomous professionals. And of course, we had much more robust health economic analysis than we would have done if we hadn't have had the health economists involved right at the conception of the project. And what's been nice moving on from this project to the work that we're doing in the future is that we've got collaborative clinical work ongoing in that substantive jobs have been funded off the back of the findings of the project. And day-to-day practical things. So some of our therapy colleagues have changed the assessment methods they use for these kinds of surgical patients on the wards based on the findings of the study, because they were there at the start where we trialled out which methods should we use, which work in terms of feasibility, which do patients like, and which can be done in the ward environment. So it's changed clinical practice, which has then carried on into substantive work. Similarly, with the research work and the research agenda ongoing, we've established a patient liaison group, which is made up a lot of patients from this original study and their carers. They meet twice a year, and they help us now with developing our service and developing the research agenda for people like them undergoing surgical procedures. And we've gone on to get other grants as well with the same clinicians involved in this project. Of course, there's always things we'd change, so there's some various tinkering with the methodology that we might have done differently, but that didn't really involve the collaboration with the people we spoke to. I think what that reflects is that perhaps we should have had stronger statistical input with more buy-in from the statisticians at the start of the project. So what are the take-home messages? Well, I think if you're working, as we've heard, with service users, with patients, the advocacy of those people certainly gets others on board. If patients say they want something, it's very difficult for us as professionals to say, well, the geriatricians and the patients might want that, but the surgeons or the anaesthetists don't. So there's a strong role for patient advocacy. Of course, it's crucial to involve them, particularly if you're trying to recruit them. If people don't like what they're doing, they'll just say no. They have a clear choice in a research study. It was very important for us to involve not only all clinicians and all disciplines, but also the managerial and those staff involved in the pathway that perhaps hadn't been involved in research projects before. We kept in very regular contact, partly because we were down in the clinics recruiting patients, so they saw us every day, and they know that the meeting you had X, Y, and Z days before the project wasn't just something that's then fallen by the wayside. It was something we were actively doing. And of course, we also did that academically through feeding back through the audit meetings, which I think was a very useful tool. And involve other relevant experts right from the start. Of course, nobody knows everything, and so it's excellent to have people help with those things that you wouldn't know about. Thank you very much.